So today we're going to talk about Zika surveillance guidance. This information was presented at the Regional Epidemiologist face-to-face meeting on Wednesday, February 22nd. Can you all see the slides? Okay, we are going to review key epi information for Zika. I'm going to provide some guidance and resources for you all related to Zika, get a snapshot of current Zika data in the U.S. and in Kentucky, and then talk about your role as regional epidemiologists or other local health department designees in approvals, testing, and follow-up for Zika. And then I'll briefly introduce the U.S. Zika Pregnancy Registry. So we'll start off with a Zika review, and we'll go over symptoms, transmission, prevention, and some resources. Zika is a single-stranded RNA virus that's closely related to dengue, yellow fever, Japanese encephalitis, and West Nile. It's an arthropod-borne virus that's primarily transmitted by the bite of an Aedes-affected mosquito, an Aedes species mosquito, an infected Aedes species mosquito. Zika was first isolated in a non-human primate in 1947 and from mosquitoes in 1948 in Uganda. Zika infections in humans were sporadic for half a century before emerging in the Pacific and the Americas. Zika was associated with only mild illness prior to 2013 and 2014. So the clinical presentation of Zika is nonspecific and can be misdiagnosed as other infectious diseases, often other arboviral diseases like dengue and chikungunya. Many people, I think about 80%, will not experience symptoms or will have mild symptoms. Symptoms typically last for 3 to 7 days. The most common symptoms are fever, rash, joint pain, or arthralgia, and conjunctivitis, or red eyes. Others have reported muscle pain and headache. Severe disease requiring hospitalization has been uncommon, and fatalities are rare. The viremia of Zika lasts several days before onset of symptoms until a week after illness onset. Zika can be transmitted through the bite of an infected mosquito, by sexual transmission from an infected partner, maternal fetal, either intrauterine or perinatal, by lab exposure, or by blood transfusion. There is currently no evidence that Zika is spread through touching, coughing, sneezing, saliva, or breastfeeding. In fact, CDC recommends that babies born to mothers who are Zika positive breastfeed, as the benefits of breastfeeding outweigh any risk. Zika has been identified in blood, semen, vaginal fluids, urine, saliva, and breast milk. Zika has been detected in these fluids, but the only known modes of transmission are semen and vaginal fluids. Transmission via blood is probable, but has not yet been established. So Zika virus is spread through the bite of an infected Aedes aegypti or Aedes albopictus mosquito. Aedes aegypti are the primary vector of Zika, dengue, chikungunya, and other arboviruses. Aedes albopictus is the primary mosquito that we have in Kentucky. Both of these Aedes species mosquitoes bite during the daytime and early evening. They prefer to lay eggs in containers of standing water, like tires and flower pots. They are often referred to as the cockroach of mosquitoes, as they like to hang out around people. They tend to stay lower to the ground and choose daytime resting sites that are less than 10 feet high. They kind of hop around on bushes. They're not the Culex mosquitoes that you would see up in trees hanging out. They tend to stay less than 10 feet from the ground. Zika can be passed from a person who has Zika to his or her sexual partners. Sexual exposure includes sex without a condom, oral, anal, or vaginal sex, and the sharing of sex toys. Male to female, female to male, and male to male transmission has been reported. Transmission is most common from male to female. It is unknown how commonly Zika is transmitted sexually. This is a question you'll probably get or have already gotten from folks calling in. Zika can be passed through sex before symptoms start, during symptoms, and after symptoms end. It can be passed even if the infected person does not have symptoms at the time or never develops symptoms. Remember that viremia is a few days before illness occurs until a week after illness onset. Virus can be shed in semen and urine after viremia has resolved. The duration of transmissibility has not yet been established. To date, cases of sexual transmission have involved exposure within a few weeks of illness onset. It's worth noting that Zika can stay in semen longer than vaginal fluids, urine, and blood. There's an MMWR that has this information. Viral RNA has been detected in semen as long as 188 days after illness onset. And so that's where the 6-month recommendation that we'll talk about in a few minutes comes from. So, as you probably are all very familiar, Zika can be passed from a pregnant woman to her fetus during pregnancy or around the time of birth. We're not sure how often this occurs. Infection during pregnancy is a cause of microcephaly and other severe brain defects and is linked to other problems such as miscarriage, stillbirth, and birth defects. Recognizing that Zika is a cause of certain birth defects doesn't mean that every pregnant woman who's Zika positive will have a baby with a birth defect. It just means that infection with Zika during pregnancy increases the chances for these problems. Because of the potential risks of Zika during pregnancy, CDC's top priority for the Zika response is to protect pregnant women and their fetuses. Pregnant women can be infected, of course, through the bite of an infected mosquito or through sex without a condom with an infected partner. There is no evidence that pregnant women are any more susceptible than non-pregnant women, and there's no evidence that the clinical course of infection is any different for pregnant women than for non-pregnant individuals. Infection can occur in any trimester. Before the current Zika outbreak, the relationship between Zika and microcephaly had not yet been confirmed. The initial association between Zika and birth defects was suspected, but in April 2016, you can see here, an article was published in the New England Journal of Medicine where scientists at CDC concluded Zika virus is a cause of microcephaly and other brain anomalies. So where is Zika now? CDC's website provides information about areas with both endemic and active transmission. If you follow this link, you can click on a US map with updated case counts, a world map with a list of countries. The data here was updated in mid-December. It's the most current map that's posted online. At that time, 61 countries and territories worldwide were reporting active Zika transmission. Note that the map shows countries in which Zika virus is being actively transmitted by mosquitoes. The orange shading of a country doesn't mean Zika is being spread everywhere in the country. It just means that it's being spread by local mosquitoes somewhere in the country. And there are several other maps on the website that you can take a look at. So you may have noticed in the last picture, or because you just already know about Zika transmission in the U.S., that there is local transmission in the U.S. Both in Miami-Dade County and Brownsville, Texas, local transmission has been reported. To date, these have been the only states that have had local transmission. Prevention. The best way to prevent Zika is to prevent mosquito bites. The recommendations are to use an EPA-registered insect repellent on exposed skin. Note that certain products have restrictions. For example, products containing oil of lemon eucalyptus should not be used on children under 3 years old. So make sure to check those out as you're advising people. CDC's resources have pretty good documentation and explanation about what can be used when. Another recommendation is to wear long sleeve shirts and pants and long pants to stay in places with air conditioning or window and door screens, and then remove potential mosquito breeding sites around standing water around your home. The recommendations for preventing sexual transmission are different for pregnant women and couples who are trying to become pregnant than for non-pregnant individuals. Pregnant women and their partners should be counseled to use condoms for the duration of the pregnancy. This recommendation does not change if a negative result is, a patient gets a negative result. Couples who are trying to become pregnant should wait at least 6 months after return from travel before trying to conceive. And then non-pregnant individuals, the recommendation for women is that if women travel, they should use condoms for 8 weeks after symptom onset or 8 weeks after the last possible exposure if they're asymptomatic. And for men, it's the same recommendations, except rather than 8 weeks, it's 6 months. So if a couple travels, you would go with the longer timeline, the 6-month timeline. Returning travelers infected with Zika can spread the virus through mosquito bites or through sex. Travelers should prevent mosquito bites by continuing to use insect repellent for 3 weeks after their return from travel. They should also use condoms or not have sex for the time periods outlined in CDC's guidance that we mentioned just a moment ago. Most cases in the continental U.S. have been travel associated. These have often been travelers coming from the Caribbean, Puerto Rico, and Central and South America. Pregnant women and couples who are trying to conceive should talk to their healthcare providers before travel, should follow steps to prevent mosquito bites during their trip, and avoid non-essential travel to areas with active Zika transmission. CDC has some really neat resources for travelers. This first one, the text messaging service. Anyone can text plan to this number, tell the phone number that they're texting with, where they're traveling, and specific recommendations for that location will be sent to them in text message. So it's really handy. There's also this TravWell mobile app. It has destination-specific vaccine recommendations as well as some packing and to-do lists, notifications from CDC about outbreaks. There's more information at the CDC Travelers Health website, but if you've got someone who's calling in asking about a specific location, this would be a great resource to direct them to. So here's a list of resources that I think are the most readable, helpful, useful guidance. CDC puts out a key messages for Zika virus disease every 2 weeks. This is the one from February 14th. And that's just kind of a go-to reference. If you have a question, it's probably answered in that. That's very easy to read. It can be distributed externally if you've got someone who's interested in Zika. And it's just a great resource if you want to read through it or if you want to refer back to it. There are also some CDC Zika 101 slides. Many of my slides, the content from my slides come from there. There's also links to guidance for preconception counseling and prevention of sexual transmission, guidance for managing infants with possible Zika, guidance for labs, an interpretation of lab results. Those are just quick links as they send out updated guidance. I will be distributing them, but you should be able to search online and they should come up pretty readily. The COCA webinars are also great. They have resources geared specifically toward clinicians to nurses, to doctors. There are some slides on there and some recorded webinars that are great to watch. And lastly, there's a literature review, which is helpful in getting a summary of what's known about Zika. So there are a number of resources out there. These I would commend to you as especially helpful. And if you have others, I'd be happy to share them with the other regional EPIs. CDC's webpage also has tons of information, has all sorts of information about prevention and testing. They have resources, publications, fact sheets, just tons of resources that can be used. They have lots of things in multiple languages, which is really handy. Here are some of those fact sheets. These are tools for healthcare providers and information for patients that you can share with providers who are testing, or you can share in your communities. They're really handy. This is a nice graphic that shows what we know and what we don't know. We get a lot of questions that we actually don't have answers for. The scientific evidence is just not available, so this is kind of a nice picture of that. So now I'm going to talk to you guys about what Zika looks like in the U.S. and in Kentucky. Here's a map of laboratory-confirmed Zika virus disease cases reported to ArboNet, and this was updated about 2 weeks ago. So far, again, this is updated as of February 15th. There were just over 5,000 cases of U.S. residents with evidence of possible Zika virus infection. Most of those, 94%, were travel related. About 4% were local transmission, and 72 or 2% of those were other. Those would be sexual transmission, congenital infection, a lab transmission, and a person-to-person unknown route. There have been 1,455 pregnant women with lab evidence of Zika, and 1,047 of those have completed pregnancies. The others are still pregnant. Of those 1,047, there have been 43 live-born infants with birth defects and 5 pregnancy losses with birth defects. This information is on CDC's website when you look at the case counts, and it's updated regularly. So now I'm going to give you guys some information about Kentucky. This is updated on February 15th as well. As of today, Kentucky has approved 354 Zika tests, so this is a little old, but not too bad. And we've had 35 cases with evidence of Zika. That is still a number. 5 have been from external labs, and 30 have been tested either at the state public health lab or at CDC, or both. For our approvals, most of them have been female, and you'll see when we look at the criteria for testing why that makes sense. But our cases have been just about half and half, a little bit more female. We've tested from newborn to 75 years. The mean age of people who are tested for Zika was almost 32 years, which is pretty similar to our mean for our cases. About 41% of those whom we've tested have been symptomatic. Almost 100% of our cases have been symptomatic. You can see that 74% reported fever, 94% reported rash of those who were symptomatic. 69% reported joint pain, and about half reported conjunctivitis. The one unknown was from an outside lab, and we were not able to get the symptom details. So about 60% of our approvals have been pregnant, and about 60% of the pregnant women have had exposure around the time of conception and or during the first trimester. Of our cases, we've had 4 pregnant cases. All of those reported symptoms, and all of them had an extended stay in a country that is having local transmission of Zika. Okay, about half of our approvals reported mosquito bites, and about a quarter of our cases reported mosquito bites. 45% reported using repellent at least some of the time, and it's not too far off. 49% of our cases reported using repellent at least some of the time. The most frequently visited locations are Mexico, then Jamaica, Costa Rica, Dominican Republic, and Miami. And the most frequently visited locations among our cases were Mexico, Haiti, Jamaica, and Nicaragua. You can see that Lexington and Louisville and Northern Kentucky and even Elizabethtown, where we have more folks, we're having more requests for approvals. And then in terms of cases, we had 10 cases in Jefferson County, and then Wayne, Campbell, and Taylor also had more than 1 case. In Wayne County, it was a family. So that makes sense why we see 4 cases there. All of the other counties either have 0 or 1 case at the time of February 15th, and that's still true today. So now we are going to talk about your role at the local level, the regional level, in conducting surveillance for Zika. I know this is a lot of text on a slide, but the main things I want you to know is that this has 2 parts: approval for testing and then response to lab results. So first, you're going to receive an inquiry from a healthcare provider who wants to test someone for Zika at the state public health lab. You're going to complete Form 2, the exposure checklist. Here's a picture of that. You probably have all seen that. This morning I emailed you all a copy of the most recent edition, and I also emailed that to you today in the handout for this webinar. This form collects demographic and exposure information. You can complete it over the phone with someone. You can send it to a provider and they can fax it in. You can determine how you want to receive this. So then you're going to determine if the patient meets criteria to be tested. So pregnant women have to have at least 2 of the key symptoms that we discussed earlier: fever, rash, joint pain, conjunctivitis, or they have to have traveled to a Zika-affected area in the past 12 weeks, or traveled to a Zika-affected area within 8 weeks of conception. Pregnant women will also be approved if they've had unprotected sex with a Zika-infected person or with someone who traveled to a Zika-affected area. And finally, if ultrasounds indicate fetal abnormalities and the patient has either a history of travel or sexual exposure, or both, the patient would be approved for testing. Here is a flow chart, and this is also included in the handout that shows you, I'm not going to walk through each of these steps with you, but you can follow along and see whether pregnant women will or will not be approved for testing. We'll have a chance to practice in just a few minutes. So the approvals for non-pregnant individuals are a little more straightforward. They must be symptomatic with at least 2 of the key symptoms and have either a history of travel or a history of unprotected sex with a Zika-infected person or someone who traveled to a Zika-affected area. And again, there's a flow chart for determining the approval eligibility of non-pregnant individuals for this group as well. Approvals for infants will come through KDPH RDS. You'll probably be talking to me or someone else in our section. CDC recommends lab testing for all infants born to Zika-positive moms or infants who have abnormal clinical or neuroimaging findings suggestive of congenital Zika syndrome, and a maternal epi-link, regardless of the results. If you get a request for testing for an infant, please call us immediately. So you've determined whether the patient meets criteria, and now if they do, you need to determine what test should be used. If they don't, maintain the form in accordance with your local record retention policy. It's important that we don't just toss these. Someone could come back later and say, well, I had Zika and I've got all these problems now, and you wouldn't test me, and then we can say we wouldn't test you because you didn't meet the criteria. So it's a good thing to keep those on hand, and I'm sure your local health departments have a record retention policy. So before going through the Zika diagnostic tests, I would like to make the point that there are no licensed Zika tests in the U.S. Rather, all currently available Zika tests at the CDC, at health departments, and commercial labs are being used under an FDA emergency use authorization. This mechanism allows unlicensed tests to be used in a public health emergency. So diagnostic tests can be accomplished using both molecular and serologic methods. The molecular method is an RNA test. Here at the State Public Health Lab, we use the Trioplex PCR. Serologic methods are the Zika virus immunoglobulin M enzyme-linked immunosorbent assay, or the Zika macroLISA. The plaque reduction neutralization test, PRNT, is conducted at CDC, and this detects neutralizing antibodies in serum. So, as I said, 3 commercial labs have been qualified to use the CDC macroLISA, the IgM. We've also got 10 commercial diagnostic manufacturers that have received an EUA for a molecular test for Zika virus RNA, and 1 commercial diagnostic manufacturer who has received an EUA for a serologic test. I just want to put this on you guys' radar because most of our testing, most of our positives are coming from the State Public Health Lab, but you could receive positive labs or negative labs from a commercial lab, and you should be on the lookout for those. So the Trioplex RRT PCR detects viral RNA in body fluids, including urine and serum. at DLS, PCR on serum tests for chikungunya, dengue, and Zika, and the PCR on urine tests for Zika only. Cross-reaction with other flaviviruses is not expected. CDC recommends that PCR testing be performed on serum and urine specimens obtained within 14 days after symptom onset. Anytime Zika RNA is detected, Zika virus infection is confirmed. The limitation is that since Zika RNA are short-lived, a negative result does not rule out infection. Excuse the typo. So the IgM test, this is presumptive detection of anti-Zika IgM antibodies. IgM testing should be performed on serum specimens obtained 2 to 12 weeks after travel or after onset of symptoms. Positive specimens indicate that anti-Zika IgM antibodies were detected, but this result must be confirmed at CDC using PRNT. Cross-reaction is likely with related flaviviruses like dengue, and a negative result does not rule out infection, especially if testing is conducted soon after onset or beyond onset of symptoms or beyond 12 weeks. And lastly, the PRNT measures virus-specific neutralizing antibodies to Zika and other flaviviruses. This testing should be done as confirmatory testing following a positive or equivocal Zika IgM. Limitations: PRNT may not distinguish the type of infecting virus and people who have been previously infected or vaccinated against a related flavivirus. There's a longer turnaround time since the testing is performed in Colorado at CDC lab. So this is a really nice picture of the timeline for detecting Zika virus infection. So the recommendation is that PCR testing should be performed on specimens collected within 2 weeks of symptom onset or the last possible exposure. And you can see why. That's when it's detectable. And then IgM testing is 2 to 12 weeks after symptom onset or last possible exposure. And then testing should not be performed on specimens collected beyond 12 weeks unless there's some extenuating circumstance. And it's worth noting that last possible exposure includes both travel and sexual exposure. So there are a few special situations for pregnant women. A pregnant patient who is beyond 12 weeks from the last possible mosquito exposure, who has had a possible sexual exposure, should be approved for testing based on the last possible sexual exposure. A negative result does not rule out Zika infection. So if someone traveled maybe 5 or 6 months ago, but has had unprotected sex with her partner who also traveled, she would still be approved for testing. And a negative test would not rule out infection by mosquito bite, but it would, likely rule out sexual transmission for that individual patient. If a pregnant patient regularly travels to a Zika-affected area, testing is recommended each time she returns from her trip, and that would be PCR testing, if it can be done within 14 days of return. If a pregnant patient was tested by PCR within 14 days of her last exposure and had a negative result, her provider may want to retest by IgM during the 2 to 12 week period, and that would be in accordance with CDC guidance. And lastly, if a pregnant patient has a history of travel or sexual exposure and ultrasounds indicate fetal abnormalities, the patient should be tested by both PCR and IgM. And we will certainly work with you all on this situation. We'll have to alert the lab before this is done. Okay, so the way we did this in the in-person training was I gave everyone 10 minutes to work in groups on these practice problems. I think what I'm going to do today is read through them and give you all a chance to get an answer in your head, and then I'll go over the solutions. So let's go ahead and get started. Okay, there are 10 of these. Number 1, a pregnant woman traveled to the U.S. Virgin Islands with her family from December 30th, 2016 to January 2nd, 2017. At the time of travel, she was 11 weeks pregnant. She reports no symptoms and no unprotected sex with her partner who also traveled. So this is the time when that handout will come in handy. The first 2 pages are these problems. And then you've got a calendar to make it easy to count back weeks. Please pretend that today is February 22nd, because that's when the problems were created to be worked out. There's also flowcharts in there for you all to look at, and a copy of Form 2, which should help you decide whether the person meets criteria to be tested, and then this, the 2 to 12 weeks is IgM, less than 2 weeks is PCR, and beyond 12 weeks is not recommended. So I'm going to give you guys a minute to look at this one, and then I will go over the solution. All right, I'm going to go over the solutions now, or the solution for this one. If today is February 22nd, this woman traveled about returned from travel about 7.5 weeks prior. So based on her travel exposure, she would be approved, and she would be approved for Zika IgM testing. Situation 2, a pregnant woman traveled from Mexico from August 3rd to August 6th, 2016. She was pregnant at the time of travel, and her estimated delivery date is March 5th, 2017. She reports no unprotected sex. She had symptoms of fever and rash, but remembers no mosquito bites. For this one, I'm actually going to have you guys raise your hands when you're done answering it, so I can know when you guys are ready. So go ahead and get started and raise your hand when you're ready. Okay, so I'm going to go ahead and go over this one. August 6th is beyond 12 weeks. She hasn't had any sexual exposure, so Zika testing would not be recommended. We would just want the OB to monitor ultrasounds for any abnormalities. Oops, sorry. Okay, situation 3. A man traveled for work to Brazil from January 4th to January 8th, 2017. He wore insect repellent and does not remember any bites. He reported a headache the week after he traveled. Should he be approved, and if so, with what test? Can you raise your hand when you got an answer to this one? All right, so he had recent travel, but he was asymptomatic. Since he's not pregnant, he would not be approved for Zika testing. All right, this next situation, this is situation three's wife. A pregnant woman presented for her first prenatal care visit last week. Her husband traveled to Brazil from January 4th to January 8th, 2017. He wore insect repellent and does not remember any bites. He reported having a headache. Should he be approved for testing? If so, what test? Raise your hand again when you're ready. All right. So she has recent travel within 12 weeks. We don't have enough information to decide which test to use. Which test to use will depend on when her most recent sexual exposure was. So if it was in the last 14 days, then it would be PCR. Otherwise, it would be IgM testing. All right, situation 5. A nurse from a local OBGYN office calls you about Zika testing. She says a pregnant patient just returned from a family trip to Cambodia. She had symptoms of fever, chills, and congestion starting on February 7th and continuing until she presented for care on February 15th. No one else in her family was ill. She tested positive for influenza A. The nurse thinks she doesn't have Zika and was calling to make sure she didn't need to test. Should the patient be approved for testing, and if so, what test? Raise your hand when you are ready. All right, so this is a situation that actually happened. The patient does meet the criteria, and even though this is probably flu, since she meets the criteria, she would qualify for testing. So she would be tested by PCR. All right, situation 6. A woman returned from a week-long backpacking trip in Costa Rica last Thursday. She is not pregnant, has not had any unprotected sex, and wore insect repellent throughout the trip. Over the weekend, she had a fever and some joint pain. She presented to her primary care provider, not sure whether she was sore from hiking or if something else was wrong. Should she be approved, and if so, what test? Okay, I'm going to go over situation 6 and then circle back to situation 5. So this woman who went on the backpacking trip, um, she has symptoms, and it's been less than 14 days since her return, and so she would be eligible for testing by PCR. So situation 5. So this patient is pregnant, and so we'll be looking at the pregnant flow chart. Does she have at least two of the following symptoms? So she has fever and joint pain. When did those symptoms begin? Within the last 12 weeks, including current symptoms. She's eligible for testing. So the truth is, this is very likely just flu, but based on CDC's criteria.
Listening to the CDC thing. So there's a CDC call about 14.
I'm going to pause you guys for just a second. Okay, sorry about that interruption. So, this patient probably has flu, but she meets our criteria, and if the provider requests testing, we're going to follow the CDC recommendations for testing. Does that make a little bit more sense? Oh, that is a very astute point. Louisville is, I'm so happy you guys are on here. That's a very good point. She does not have joint pain. I was getting mixed up. So let's look at the situation again on the flow chart. Has she had at least two of the following symptoms? No. So we go down. Has she traveled to a Zika affected area? So Zika is endemic in Cambodia. So we would say yes. So when did the patient return from travel? Within the past 12 weeks. Does that clear things up at all? Again, this is very likely flu, and I wanted to put that in there because there are some really strange situations that you would think, oh, that person probably doesn't need to be tested, but we want to be following CDC's recommendations and catch anybody who would meet CDC's criteria for testing. That is a very good question. Thank you so much. And if you guys have more questions, stop me. Okay, we're going to move up to practice question 7. Okay. Oh, that's a great question. Sorry, I almost missed that. What's the difference between endemic and active transmission? If you look at the CDC website, the CDC website, the active geo, the one that shows you the map. Actually, I'm going to click on that if I can. Is that okay? Okay. You guys will have to bear with me for just a second. Okay, so CDC's website shows areas with active transmission. This would be where it's being reportedly transmitted by local mosquitoes. And this is, there are a lot of countries in the Americas, and you can see all of these. CDC is also, and you'll see on this list that Cambodia is not actually on this list. So you would need to look at the endemic transmission list, which you will notice on the Form 2, there are 2 different links. Haha, here we go. So these active transmission countries are countries where they're currently experiencing outbreaks and have had local transmission. Endemic countries are where they've reported cases of Zika in the past, and they have some cases, but it's at kind of a normal lower level. And they've got a whole list of countries. Here I am talking about how easy it is to find. Here we go. Here are the countries in this travel message for South Asia for endemic Zika. So that's a really a really good point. Whenever I get a request, and whenever you guys will get requests in the future, if it's a country that you're not familiar with, go ahead and look it up on CDC's traveler page, because there's no way you could memorize all of those countries. Okay, let's see. Do you guys have any follow-up questions? Yes. So this is a really great question. In fact, I wish that this had been asked when everybody was here. We would treat endemic and active countries the same here. Yes. So although the risk would be higher in active transmission countries, we would expect to see something come out of this. If more likely if it were in inactive transmission countries, those who have traveled to an area that has endemic Zika would still fit all of the recommendations for testing. So yes, we would treat endemic and active transmission countries the same in terms of testing approval. Any additional follow-up questions? Okay, if you guys have more questions, feel free to, well, let's see, do I? Okay. Feel free to ask them. So, for this situation, a couple honeymooned at a resort in Jamaica in late October. Neither recalls having any mosquito bites or any Zika-like symptoms. The woman was not pregnant at the time of travel, but she is now 10 weeks pregnant. If you guys have an answer, you can raise your hand. Okay, I'm going to go ahead and go over the answer for this one. The couple should have waited until late April, the 6-month mark, to attempt conception. She's beyond the 12-week range for IgM antibodies to be detected if it was transmitted by mosquito, but she still meets criteria for testing since she's had unprotected sex with her partner, who may have been exposed, if in fact the father of the child is her partner. So it would be PCR if sexual exposure was in the last 14 days. Otherwise, Zika IgM. Are there any questions about that? And even with negative results in this situation, the couple would still be advised to take precautions and to use condoms for the duration of the pregnancy. So, situation 8. A woman lived in Haiti until mid-September of 2016. She then visited Mexico and Brazil before moving to the United States on October 1st, 2016. She had no signs or symptoms, no known mosquito bites, and no unprotected sex since arriving in the U.S. You can raise your hand if you've got an answer. Okay, so based on the information we have, 12 weeks from the last potential exposure would have been December 23rd. So we would just monitor ultrasounds if the patient was pregnant. Okay, situation 9. A woman went on a cruise to the Bahamas from November 29th through December 3rd, 2016. She had no symptoms and remembers having a few mosquito bites the day before she came home. She is now 6 weeks pregnant. Should she be approved? You can raise your hand when you're ready. Okay, so travel within 8 weeks of conception makes her eligible. If today is February 22nd, she needs to get her Zika IgM specimens collected this week. Any questions about that one? Okay, and finally, another real life event. Almost. A local health department nurse alerts you that a couple returned from vacation in Cuba about 3 weeks ago. Being the astute epidemiologist that you are, you determine that the pregnant woman will be approved for testing. You get a call from her husband, who's in a frenzy. He states he needs to be tested. He reports he began to feel ill upon return with symptoms of congestion and headache. Later, he mentions that his wife said he had a rash and that he went to the eye doctor for red eyes yesterday. When you ask for more details, he says his left eye was irritated and the eye doctor was unable to determine the cause. He reports some use of insect repellent and does not remember whether he was bitten by mosquitoes. If you've got an answer for this one, you can raise your hand. All right. So his symptoms are not consistent with characteristic symptoms of Zika. If he truly had conjunctivitis from Zika, it would be a systemic issue and not just one eye. So his pregnant wife will be approved for testing, and they should be encouraged to use condoms for the duration of the pregnancy, but he does not meet CDC's criteria for testing. Okay, I'm going to go ahead and move on. Thank you guys for your interaction on that one. I'm going to show you a CDC Zika widget. CDC has these widgets that can be put on your websites. There's a topic of the week. There is a pregnancy and Zika testing widget and a know your risk widget. All of these are really helpful, and I'm going to show you guys this one. Oh, hold on just a sec. So we had a question about testing if the headache and rash would not be sufficient for testing the man. So they have to have at least, a person who is not pregnant has to have at least 2 of the 4 key symptoms, and those are fever, rash, conjunctivitis, and joint pain. So he had rash, and he reported conjunctivitis, but then he stated that it was only one eye, so that wouldn't be conjunctivitis. So without 2 of the 4 key symptoms, we're not going to approve him for testing. Ooh. Did I answer that question? I may have. Let me make sure I didn't delete something. Oh, no, okay. Okay. So this widget right here, and I've included a link to all of the widgets, it walks you through testing, interpretation, recommendations for pregnant women related to Zika testing. So if I start and I say I'm a state health department official, and it gives me a warning that this is based on guidance and this is not intended to be a substitute for professional judgment. I want to know if I need help deciding if Zika testing is needed. This is also a great resource for interpreting results. Does my patient live in an area with active Zika transmission? No. Do they travel to an area with Zika transmission? Yes. Was this a single trip? We'll say yes. Did they have symptoms? Let's say no. How long ago was possible exposure? 2 to 12 weeks. And it will tell me what to do. So this is a really handy tool if you want to check yourself, if you feel unsure about a pregnant patient. This is a really handy tool to walk through that. And I've included that link. So you've gotten the inquiry, you've gotten the exposure information, you've decided whether or not the person meets criteria, and then you're going to enter the information in GenTrack. So GenTrack, I emailed you all this morning about access to GenTrack. It is accessed through COG. It's a secure web-based system for assigning Zika testing approval IDs. So you determine that a patient is eligible, you enter this information, right here you can see, and this matches the Form 2. It has the same information, so you just directly put that in, and you press save. And when you press save, this number up here that's a 0 becomes the approval number. So the approval number would be KYZIKV, and then whatever number it generates. Make sure to write that number down because you're going to be sharing that with the healthcare provider. So when you contact the healthcare provider, make sure to get any information that you did not get on Form 2. I recently got a request for testing, and the pregnant woman was term, and she came in and she had every single symptom, but there wasn't an onset date. So I knew that we had a really sick woman who was about to deliver a baby, and as I called the provider to get more information, I was ready with my approval number. She said, oh, I marked all of those out because she didn't have any of them. So getting that extra information from the provider was really key. So you want to make sure that the healthcare provider and the patient have education on prevention and transmission, provide the approval number for GenTrack, and coordinate the collection of specimens. We're going to talk about each of these more specifically. This is typically going to be the regional epi in most places, or the local epi. In Louisville, I know you all have a communicable diseases team. In Lexington, I think the two epis there will serve as each other's backup. So in regions that don't have a team, we can be a backup as well at KDPH. So you want to make sure that healthcare providers know about how to contact their local health department designee for testing, that they know about symptoms, prevention, and transmission, and that the patient knows the following. Practicing enhanced mosquito precautions for 3 weeks after return from travel and during all future travel. That pregnant women and their partners should postpone travel to Zika-affected areas, both endemic and active transmission, and use condoms or abstain from sex for the duration of the pregnancy, as we discussed earlier. And then finally, educate couples on the risk of sexual transmission according to the latest CDC guidance. There's many situations where when you are talking with a healthcare provider, they are willing to go over this information with the patient, but you also can cover the information with the patient. You can, that's up to your discretion about how that's handled. You just need to ensure that the patient is educated, and note that in GenTrack and on Form 2. So many of you have seen these forms. These are the collection and submission instructions, and then the 2 submission forms if specimens are not ordered through outreach, or if tests are not ordered through outreach. There's a link to the lab's website where they have the most updated versions of these forms. You will share these with the healthcare providers who are ordering testing. So one thing that is on this form that hasn't yet been updated is that for either PCR or IgM testing, providers should submit both 2 serum separator tubes and at least 3 mLs of urine. Results for Zika will usually be available within the week if all testing can be performed at DLS in Frankfurt. Do not send specimens to DLS on weekends. It's preferred that the lab collect the specimens, refrigerate the urine, spin down the serum, and refrigerate it until either approval for testing is obtained or until it can be shipped during regular business hours. The turnaround for CDC PRNT testing really depends on the volume of tests that they are receiving. So it typically takes a couple of weeks, but I'm not sure what that will be like this summer and when there's a lot of testing going on. So again, this goes over the instructions for if you have access to outreach, if you do not have access to outreach, and then packaging and shipping. In some areas, local health departments are willing to collect specimens, and in some areas, they would prefer that that be done at the healthcare providers. So make sure you know what's the policy in your area. So we've gone over approval, and now we're going to go over response to laboratory results. Don't worry, this part is much shorter. So you might receive lab results by fax from a commercial lab, by ELR, or as you check outreach for DLS results, you want to search for MVS, which is the IgM test, and MVPCR, which is the PCR test. Use the most updated guidance to interpret results and determine next steps. So if there are any special cases or tricky situations, just contact us and we will work with you. So there are a few ways to have evidence of a possible Zika virus infection. These are positive Zika virus RNA, NAT, on either serum or urine, and that's from the triplex PCR test, or another PCR that's done at a commercial lab. If the PCR is negative or it hasn't been performed, we have an IgM positive or equivocal, and PRNT, the Zika value is greater than or equal to 10, and dengue is less than 10. And then finally, we have recent flavivirus infection. Specific virus cannot be identified, and that is still treated as evidence of Zika. To get that, we would have a PCR negative or not performed, IgM positive or equivocal, and PRNT values greater than or equal to 10 for both Zika and dengue. And this information I included in your handout. The last page is an interpretation of results for pregnant women, but it actually, if a non-pregnant individual had these results, you could conclude the same, whether it's recent Zika virus infection or something else. I think that's a really handy chart. Oh, and here it is. And this is a hyperlink, and you can follow it online. And I believe they just updated this document this month, or in February. So next steps, this is important. If a non-pregnant patient has evidence of Zika or an unspecified flavivirus that cannot be identified, follow up with the provider and enter the case in NEDS. If the patient is PCR positive during mosquito season, environmental health actions will have to be taken. Oops. If a pregnant patient has evidence of Zika or unspecified flavivirus infection, enter the case in NEDS immediately. KDPH will follow up with the provider and do all follow-up with the pregnant women. So if you're not able to enter it in NEDS immediately, please give me a call so that we can be aware of this and start follow-up as soon as possible. Again, if the patient is PCR positive, environmental health actions will have to be taken. And then if a patient does not have evidence of either recent Zika or unspecified flavivirus, file the lab report at the LHD. If the testing was performed at or ordered through the local health department, make sure that the provider gets a copy of the results. So you've received the lab results, you've interpreted the lab results, and determined the next steps. Now you need to follow up with the provider. So for negative results, as I just said, if the results indicate no evidence of Zika, you just file the record in accordance with the local policy. And if you ordered the test or performed the test at your local health department, or if someone at your local health department did that, make sure that the provider gets a copy of the results. If the results indicate a possible recent Zika virus infection for a non-pregnant patient, make sure that the provider gets a copy of them. Coordinate with the provider who's going to inform the patient. A lot of times the patient knows that the provider ordered the test, and so the patient is expecting to get that result from the provider. Educate the provider on preventing transmission and ensure the patient is educated on preventing transmission. So one thing to note here is that if this is coming from a commercial lab, then this may be the first interaction that you have with the provider. So that's why this education thing is important, and just reiterating, especially if they're being encouraged to do things that, like using condom for 6 months. That's a long time, and to have their provider reiterate that information is very helpful. Or you may be, helping them with education. So here are some handouts which are really handy. They're from CDC, of course, and they can be distributed when you send a fax of the lab result, so that the person can take this home and have this in their hand and know what it means for them to have a positive Zika test. Again, these resources are available in a number of languages. Okay, so if any patient is PCR positive during mosquito season, you're going to take environmental health action steps. Okay, I'm going to answer this question. By what methods are lab results given to the local people? I'm not sure if I totally understand the question. If you are, as a health department, ensuring that the provider received a copy, you may be faxing that. Does that answer the question? I'm not sure if I have a great answer I'm not sure if I know what you're asking. As soon as we hang up, can I give you guys a call and we can talk about that? And I'll make sure to distribute the information by email if it's something that others might have a question about. Okay. Thank you for your question. Okay. So, environmental health action steps. Notify environmental health in the patient's county of residence to discuss the case. Once you hand this off to environmental health, you will likely not be a part of the site visit or anything like that, but your responsibility is to hand it off to environmental health in the patient's county of residence. Local health department environmental staff will conduct a site visit. They will provide the homeowner with mosquito-specific handout information to prevent breeding sites and reduce bites. The results of that environmental health assessment will be shared with the Division of Public Health Protection and Safety here at KDPH, and if necessary, the Division of Public Health Protection and Safety will contact and coordinate additional adulticide spraying in the area. So, enter the information regarding the case into NEDS. Okay, this information should be entered within one business day. Based on the reg, choose the appropriate case condition and status, add the correct tests, and then use the general comments field to record additional testing information, travel information, signs and symptoms, and documentation of education and environmental response. There are some tests that are not available just in the test menu in NEDS, and if you look at the algorithm for testing, you'll see that having a negative result is important, and if we can't capture that in the regular testing menu, we want to make sure to capture that in the general comments field. Additionally, it's very important to the folks here to have documentation of education and environmental response actions. If these are not included in the general comments, the entry won't be approved until they are included. And we'll talk about that a little bit more in just a sec. So I've included information about the CSTE case definitions. The clinical criteria is a person with one or more of the following not explained by another etiology. So clinically compatible illness, complication of pregnancy, or Guillain-Barré syndrome. The epi-link would be related to travel, sexual contact, blood products, organ or tissue transplant, association and time and place with a confirmed case, or a likely vector exposure. So this is something that I've created to help me determine which category a patient falls into. There are 50221, which is Zika virus infection, and 50223, which is Zika virus disease. And there's a congenital and a non-congenital. So there are a couple of different things that this could be. It's really important that you get it right, because in NEDS, if you choose the wrong case condition, you will have to re-enter all of the information. So one thing that I've been doing with some of the cases that I've entered is to enter the lab information and then separately to create an investigation and then to associate them. So if I make a mistake, I don't have to start from scratch. But that's up to you how you all want to do that. If you have a question about maybe what case condition your case is, I would be so happy to talk to you guys about that. I know having 4 different conditions just for, or categories just for non-congenital cases is pretty confusing, or it can be. So if you want to talk through that before your first few or even down the road, I'd be happy to help you all with that. I've also I've adapted a table from CDC guidance, including some of the most common case conditions and case statuses that we have gotten. And so I've included, like you can see on the first line, if the IgM is positive or equivocal and you have those PR and T values, this is the interpretation, and this is what the case condition would be with or without the clinical criteria. So this is just a resource for you all to try to help with knowing which condition to choose. Okay, so in the test results menu, you have to click the search button. In the new window, type Zika and in the test name search bar. Make sure to select long list and then click submit, and you will get this. These are all the Zika tests that are in NEDS. You want to choose the appropriate test. So I have right here Zika IgM is called this thing with 2 different specimen types. Same thing for PRNT and then triplex PCR. I want to make a note about the PCR. You will have to enter it as 2 separate tests, but most people who have the PCR done, there's a serum and a urine, and we would like both of those results. So, for NEDS entry, use the general comments field to record testing information for tests not available in NEDS. Location and dates of travel, signs and symptoms, documentation that education was provided, and description of environmental response actions. Some of your fellow regional EPIs have been gracious enough to let me use some of their work as an example, so you can see that it doesn't have to be the exact same, but people have a slightly different way of doing it, but they've included the key information. So you might be the person doing the education, you might not. There may be no environmental health actions based on their test or based on the weather, but you want to make sure to record those things. Those are the things that I am being required to provide. So here are just some tricks or tips for entering Zika cases. Make sure to include all test results. I'm sure you are tired of hearing me say that. For the illness onset date, use the onset of symptoms. And if the patient was asymptomatic, use the date of collection. That is what the ARBONET criteria are, so I want to be in line with that. For diagnosis date, use the date of the final result. So if it were an IgM, you would want to use the date when the PRNT came through, because that's when we know it's actually a possible Zika infection. For state ID, type KY, ZIKV, and then that numeric approval number. For type of arbovirus, select flavivirus, and then for disease acquisition, in that section, include travel exposure. Okay, and then this is just a brief introduction to the pregnancy registry. CDC has funded 45 jurisdictions to participate in the pregnancy registry, and the registry collects information about pregnant women and their infants who test positive for Zika to look at outcomes. This data is going to be used to update recommendations for clinical care, to better plan services for pregnant women and their families, and to improve prevention of Zika infection during pregnancy. At KDPH, the Division of Epi and Health Planning is working with the Division of Maternal and Child Health to collaborate on the Zika pregnancy registry and Zika birth defect surveillance. We report and actively monitor pregnancies and congenital outcomes among symptomatic and asymptomatic women with evidence of Zika. So that's not something you all will have any responsibility for, but I wanted to make sure you all knew about it, that that's something that we're doing in the Division of Epi and in Maternal and Child Health. Here's a list of references. And then here's my contact information if you guys have any questions about that. I'm sure there will be questions that come up as we transition into this, this regional approach, and I am happy to support you guys in whatever way that I can. So if there are any questions right now, I'll take them, and if not, we can continue the conversation offline. All right. Okay. Got a question on the line. This is an excellent question. So the question is, if someone from a different jurisdiction comes to your county for healthcare, who should handle the case in this situation? So if the case is out of state, that person would be directed to their own state. I know that's what we've done with Indiana. There's been some over-the-border stuff, and their residents are being tested and taken care of in their state, and our residents are being tested in our state. If it's a county issue, if the person is receiving prenatal care, let's say in Louisville, but they're really a resident of Meade County or something like that, the responsibility would be in the regional epi or local health department designee who covers the county of the patient's residence. So when you talk to your providers in the area, if they're sending you something for someone else's county, say, I went ahead and sent this along, and I can provide you with fax numbers if you don't have each other's fax numbers, to David Day, the regional epidemiologist for this region, who will be approving the test for residents of this region. In the future, if this comes up again, you can just send it directly to him. So there's going to be a little bit of time lapse that it takes to make sure your providers know where to send it. We don't want to overburden the people who just happen to be in cities where the big hospitals are. So it will be based on the patient's county of residence. Does that answer the question? If it's an infant or newborn, does that make a difference? Okay. Most infant and newborns will be followed because we're following their moms. And so in that sense, we at KDPH will be doing the follow-up with them. If there is an infant who presents to a mom presents to the hospital and is having a baby right now, and we didn't know about her, we'll have to kind of take those situations more one at a time. We certainly would like to take the lead on those. And if you get a call about that, just call up to us, and we'll try to take care of that for you all. Because I know if you're in a place where there's a big birthing hospital, that you would probably be the first place to get a call. So you could just call us with that, or give the person our phone numbers to get in touch with us. We have a couple of people who can handle that up here. Okay, I want to thank everyone for participating in this call. If you have any questions, please don't hesitate to contact me by phone or email, and I will get back to you and hopefully be able to give you guys the support and resources that you need to do this well. I have all the confidence in you all, so thanks again.